Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. So I hope you are having a good spring or a good April so far as we are well into the month. And I'm just happy the first quarter is completed and now we are into the second quarter. So a couple of things. I want to focus on another element of the medical decision-making in E&M because this is a question that comes up quite a bit. So this is going to be what I call one of my quick hits today. And just so that you can have some clarification if you are an internal auditor or an external auditor, sometimes this part is missed. And I just want to make sure that you don't miss it if you are somebody that is reviewing a record. I know it's something that I see a lot of times, but also that you're not overutilizing this element as well. But before we get into that, the Codecast podcast is also brought to you today by Just Coding. You want to stay ahead of CMS changes, sharpen your coding skills, and earn CEUs all in one place? Just Coding is your go-to resource for expert guidance, coding quizzes, and executive tools. Save $5 on your subscription today at hcmarketplace.com/justcoding justcoding.com, and enter code SAVE5 to take your coding to the next level. So we appreciate that sponsor. Okay, so which element am I actually talking about when we look at medical decision making today? And it's interesting because there's so many elements. Actually, not true. There's 3 elements. There's so many components of that elements is what I meant to say. But what I'm looking at is what happens when there is a provider that goes over information with the patient, but the patient doesn't want to adhere to what the provider says. So this question comes up quite a bit, and Catherine S., I appreciate you sending me this question because this is something I deal with, and she's one of my Coding Corner clients, so I appreciate the insight here. But she says, Terry, we're having difficulty explaining certain types of risk of management and getting people to understand, and they get hung up on examples in our charts, and under risk of management, they don't understand how to score or how to weight certain things. So I'm giving you an example, and she says that her staff, coding and auditing staff, feel that this could be minimal, but she's saying that she feels it could be low or moderate, and she was just wondering what my take on this is. And, when the patient decides that they don't want to have surgery, and so they decide that they're going to just rest it or ice it or have PT or something like that. And I like her term. She says some people call it as low-ish. And that's tough because I know that there are a lot of things that are borderline, because when you audit or even when you just level E&M codes, there are borderline opinions because it's very subjective. But here's an example. It says, review MRI today shows evidence of a left small re-tear with root involvement, and then goes on to say that their activities are still limited, unable to hike with this. They want to continue pursuing conservative treatment at this time, avoiding high impact activity. I do recommend surgery. I informed that arthroscopic partial meniscectomy versus possible root repair was necessary. However, the patient said they want to continue to see if their physical therapy and exercises at home will improve strength and stability, and at this time we'll just monitor pain and let us know if they decide to go ahead and get surgery. So this is where the question comes up and says, the coders only want to or the auditors internally only wanted to give credit as minimal because nothing was done. Patients basically said, I'm going to continue to do what I'm doing. I'm going to go and, do my exercises. And they actually were looking at that as minimal medical decision making. So here's my point on this. If you look at CPT and you look under 2025, the page 8, under guidelines for selecting level of service based on medical decision making, there's a bold bullet 3 on the right side of the page, and I like to give you chapter verse, and it's under the risk of complications and or morbidity or mortality of patient management. It says, and I quote, "This includes decisions made at the encounter associated with diagnostic procedures and treatments. This includes the possible management options selected and those considered but not selected after decision making with patient and our family." So if the provider discusses their preferred management options with the patient, they get the risk credit even if that is declined. Now, I don't let them keep getting that over and over and over again, because let's face it, if the patient comes back and they're still in pain and the same discussion is had, the next time, if they're continuing with PT or need a new script for that, then I may give them low, but I'm not going to keep giving them a moderate medical decision making if that's the case, because it's already been done. But they do get it the first time that this is a discussion. And then let's say the patient finally decides to have the surgery and adhere to something they're scheduling, and there's also risk factors or non-risk factors in that discussion, then I'll give a level of service based on that discussion because something's changed. So many patients, especially in orthopedics or neurosurgery or surgery specialties, they do prefer conservative measures. They prefer PT over surgery as long as they can, maybe, medication. I'm a perfect example. I've got frozen shoulder. It's so painful at times. And I just tolerate it because it's really about physical therapy and, oh my gosh, on and on and on. If you're over 50 female, just know it's coming. It absolutely sucks. But surgery to me just isn't an option right now. So does that mean my doctor doesn't know what they're talking about? No. And does it mean that they don't get credit for giving me their insight and that risk and what that risk would mean, if there's any risk factors as well for me beyond just the normal risk factors of surgery? They still get credit for that just because maybe I'm not considering it, or in this case, the patient doesn't consider that surgery. The doctor still says this is the best option. This is what would cure or relieve the problem, or at least make it better. And that's why your physician gets that credit. And so when the staff or your coding or auditing staff, try to err on being extremely conservative here, I understand that. And it's hard to explain sometimes, well, the doctor's not doing anything today. Well, you're not doing nothing. They're still, again, in their workflows, in their discussion with the patient, we are seeing how they're getting from point A to point B. And the doctor's the one that is directing the care as far as what the risk is. The patient may or may not be choosing to take that advice. And when that's the case, it does not penalize the physician for getting the level of service that is appropriate for that encounter. So it doesn't hurt the patient either. I mean, it's a copay is a copay, but you have to give credit where credit is due. Now, the only thing that I caution about is giving it every single time for the same thing. That wouldn't be appropriate. It would be like, having an MRI done last year and you didn't charge for it, so you get to, have it in the data points, but you don't get it every single time that it's listed in the patient's chart every time they come in. You can only get it once. So you have to make sure that you're not, duplicating those services every single time, or I should say duplicating that risk. But that is one part and one element or one component of that element and risk of complications and morbidity or mortality of the patient management that I was really happy that AMA decided to clarify so that physicians can get credit for their expertise and their thought process during the encounter with the patient. Just make sure it's well documented and that the patient did decline if they did. I know in cardiology, we have patients all the time where it's recommended they go to cardiac rehab and they're like, no, I think I'll just be at home. Or how about urgent care centers to say, you know what, your CO2 is really low right now and we need to have you go to the hospital. And the patient's like, no, I'm fine. Well, no, you need to go to the hospital. Or they're having chest pain and they have an abnormal EKG. You need to go to the hospital. No, I'll just monitor it. Your doctor gets credit for making the decision that this needs to be elevated to the hospital, to surgery, to, whatever risk they feel that would add to the complexity, or I should say the complications of the patient. That's that third element of medical decision making. And we do give it at the time of the encounter. Just be careful not to give it every single time if it repeats itself. Okay. I sure hope you guys can't hear that dog outside my window. He will not stop barking, but I can't seem to mute it, and I don't want to close my window because it's a beautiful day. So I apologize if you hear that dog out there. He's actually howling. He's chasing rabbits, and he's mad because they keep going in his space. It's just kind of funny. But I guess that's my personal tidbit today. But anyway, hopefully everyone, you're going to have a good week this week. And I just hope that you have some weather that you're liking. I know I saw in some parts of Wisconsin and Pennsylvania it was still snowing, and here in California we are in the high 70s already. So, I hope it's going to warm up for you soon. Everyone, make it a great rest of your week. Make it a great day, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.